We are delighted to be here today at VPM's Thorle Bajirao Peshwe Sabhagraha, surrounded by the peaceful greenery of the Thane College campus. The theme for this year's conference, Collaborative Care in Pediatrics, highlights the shared expertise in addressing the diverse and complex challenges faced in pediatric healthcare today. Throughout the day, we will explore a variety of topics ranging from vaccine updates and cutting-edge diagnostic tools to critical insights into managing conditions like gut health, pediatric infections, and more. We are privileged to have an exceptional lineup of speakers, moderators, and panelists with us who bring with them a wealth of knowledge and experience. Apart from these sessions, we also have some exciting elements on the agenda, such as the live online quiz. We encourage all of you to actively engage in these sessions. We might not be able to take questions, but if time permits, we will definitely take a few, and you can always connect with our speakers later on. Now, before we start our conference, a few announcements. Please keep your mobile phones on silent mode. Lunch will be served from 12 to 3 p.m. As sessions will continue during this time, we kindly request that you return as soon as possible. Due to time constraints, felicitation of all the speakers and panelists has been organized outside the hall at the felicitation station, and one of us will accompany you to the same. So, without further delay, let's officially begin TAPICON 2024. We hope you share our excitement and wish you all a productive and enriching experience ahead. Thank you.
So let's get started. Our first session for the day is rhythmic joint.
I request our TAP President, Dr. Praveen Gokhale sir, to please say a few words.
All the delegates and faculty who have come here today to Thane to participate in our 14th edition of TAPICON 2024. And without much delay, we are here for the academics. So I ask the MOCs to start with the session immediately.
So let's get started. Our first session for the day is rhythmic joints, for which I would like to call upon stage our moderators, Dr. Sudha Mungal sir and Dr. Ramesh Iyer sir, and our panelists, Dr. Sunil Junagade sir, Dr. Amol Jaibhai sir, and Dr. Archana Khan ma'am. So let me introduce our moderators first. Dr. Sudha Mungal sir, he is consultant pediatrician and neonatologist at Curie Hospital and Oscar Hospital. Dr. Ramesh Iyer sir, he is lead pediatrician and director at Indian Vaccination Center, a franchise-based vaccination clinic. He is organizing chairman at TAPICON 2021, MahaNeocon and MahaPedicon. Let me introduce moderators and panelist. Dr. Sunil Junagade sir, he is professor at Rajiv Gandhi Medical College and Chhatrapati Shivaji Maharaj Hospital. He has more than 26 years of experience in pediatrics, including pediatric and neonatal intensive care, more than 10 publications in national and international journals, undergraduate and postgraduate teacher, and advanced course in medical education. He is consultant pediatrician at Siddhivinayak Hospital, Thane. Dr. Amol Jaibhai sir, he is consultant pediatric infectious diseases and transplant infectious diseases, affiliations at SRCC Children's Hospital, Mahalakshmi, Mumbai, Jupiter Hospital, Thane, CTC PHO BMT Center, Borivali. Achievements: Young ID Fellow ASPID 2018, Travel Award ASPID 2018. He has 7 publications in Index Journal and 3 books chapter and 2 IIP guidelines. Dr. Archana Khan ma'am, she is consultant pediatric rheumatologist at MRR Children's Hospital and SRCC Children's Hospital. She is consultant pediatrician at Masina Hospital. She is co-authored at multiple papers in renowned journals focusing on rare pediatric rheumatic diseases. International contributions: presented multiple posters at global conferences including ISSAID and press, sharing insights on rare conditions and telemedicine in pediatric rheumatology. Leadership and teaching: she is actively involved in educational fellows, organizing workshops and participating in international research projects, furthering the understanding of pediatric rheumatic diseases. Over to you, ma'am and sir.
Good morning all. Thank you TAPICON 24 organizers and my seniors. So we'll start first session on rhythmic joints. This is a case based. So 2.5 years old male child brought with complaint of left knee swelling since more than 1 year duration. History of limping since more than 3 months duration. History of weight loss about 1 kg over 1 month, and history of fever on and off since last 10 days. So negative history, there was no history suggestive of any bleeding diathesis, no history of any abdominal pain or frequent loose stools, no history of any skin dryness or any skin rashes. There was no history of any night pains or morning stiffness in pain, and there was no history of intake of any unpasteurized milk. So this was a second born full-term normal delivered child, 2.5 kg, and neonatal period was uneventful. Immunization history, child was vaccinated till 1 year of age at government center, and developmental history, his milestones was age appropriately. And family history, there was no history of any TB or TB contact or any bleeding disorder or clotting disorders. So, yes.
Yeah, so good morning everyone. So let's get started with the questions to the experts. And in the meantime, we'll put few questions to the audience also so that, everybody is interacted. So Archana ma'am, clinically, how do you differentiate between arthralgia and arthritis? And how will that ultimately help you a diagnosis and a prognosis in a particular case?
A very relevant question, because a child with joint pains is not equal to arthritis. So when this child presented to us with arthralgia, it would mean there are no signs of inflammation inside the joints. Inflammatory joint will have swelling, redness, all the inflammatory markers that we've read about. And clinically, in all the movements, active or passive, there would be pain and there would be stiffness, a very important differentiating marker. And of course, it would change the prognosis because arthralgias are generally related with other differentials like viral infections, mechanical or something like that. And when the reason goes, the pain goes, but arthritis could be morbid.
So in further analysis of arthralgia, how does one differentiate between articular, non-articular, or articular or extra-articular?
This, I would say, would be more challenging because the swelling is generally diffuse over the joint area. But if carefully examined, in the articular pain is very deep, and like I said, it would be an active and passive movement both. In periarticular pain, you might not find pain during passive movement. It's more during active movement. There will be no inflammatory signs on the center of the joint. You might find point tenderness around the joint. And of course, investigations would corroborate it further.
So Dr. Sunil, we are practicing pediatricians. So suppose you saw this patient at quite early, say 2 weeks or 3 weeks of the illness. How would you go about analyzing it?
Okay, good morning to everyone. First of all, the age of the patient. So even if you are presenting this child as a child who is 2.5 years of age and is presenting with a monoarticular, a single joint involvement with pain and restriction. So for me, unless and until at that age there is no chance of a significant injury unless and until there is an accident. So if a trivial fall is there, I will classify it as a traumatic or a non-traumatic injury. So that will not lead to the differentials which are usually classified in that area. So for me, this child has a single joint involvement without trauma. So whenever it comes to monoarticular involvement, my first go-to differential would be an infection. Unless and until there is a positive history of some bleeding diathesis in the family or there is evidence of some ecchymotic patches or some kind of swelling immediately after the fall. But if I am not wrong, the history says that the parents did not talk about a major injury, right? So for me,
antecedent.
exactly. So that might usually be a coincidental observation by the parent that he has a fall and then followed by that they notice that there is a swelling. But usually this doesn't look like a traumatic, but still keep my options open and think about a monoarticular involvement, so leading to some kind of infection, and it will require further evaluation.
So on ODP, he was absolutely fine in 12 months of age. Then there was history of trivial fall, followed by swelling was noticed after 4 to 5 days by parents, for which they consulted local physician and X-ray done and some analgesic received. X-ray was normal that time. Swelling reoccurred at the age of 18 months. That time child was referred to orthopedic surgeon and there he was investigated. So his CBC showed hemoglobin 11 gram, total count 7,800, lymphocyte predominant and platelets were normal like 2.8 lakh. ESR was 15, ANA was done, that was 2 plus, and Montux was done, was positive. On paper, what tuberculin unit was used was not mentioned, and MRI done that time showed mild synovial thickening with effusor. So synovial fluid aspiration done that time showed TB PCR and culture was also negative.
Yeah. So based on this, Archana ma'am, generally we do CBC for everything. So CBC in a case of arthritis, how does one analyze it?
This is actually a very good marker in a case of arthritis. So most of arthritis case, especially in our child with chronic arthritis, we are going to find anemia. So the marker would actually be leukocytosis or leukopenia in this child. Leukocytosis with neutrophilic predominance or lymphocytic predominance to again tease out whether we are dealing with a mimic-like malignancy, not in this child, it's 1 year, but you're generally speaking, a malignancy or neutrophilic, we might be going into a rheumatological path here. And thrombocytosis is again a sign of inflammation. So thrombocytosis, leukocytosis, anemia, you're dealing with inflammation somewhere. Pancytopenia or at least leukopenia, later on thrombocytopenia, you may be going towards connective tissue disease after ruling out infections and things like that.
Dr. Amol, same with ESR. Like we keep doing this. Is there any importance, or it is just a?
Uh, Doing ESR is okay, fine. Maybe it can be increased more in rheumatological disorder, but in this kind of patient, because of a low.
What cutoff of ESR is significant? More than 20. Okay, fine. Archana ma'am, ANA positive, as in this patient there was an ANA positive. So can you just generally tell the audience, we do keep doing ANAs in all these patients. So ANA, is it significant, non-specific, and how often do you get false positive ANAs?
Can I ask you one question? All of you. That at 1 year first episode of a single joint involvement, trivial trauma, male child, would it kind of at that time, if you were a pediatrician, would you think of something else? That means can hemophilia present like this?
I would definitely. In fact, first time when I saw that, is my first time it was hemophilia. To begin with,
Here, history of any bleeding from even vaccination site or circumcision becomes very important for us.
But look, that history was asked for and it was negative.
Yeah, you mentioned it in the negative. Here, with in regards to ANA, my first question would be, why did we even do it? Does the dog wag the tail or the tail wag the dog?
I think the possible diagnosis at that point in time for a monoarticular arthritis, which was already going into chronicity, was a oligoarticular JI. So for that one reason, then ANA was done, and that would have been the thought process. Definitely, we were not involved at that point in time, but with due respect to whoever was treating, that was what the idea.
So with that thought process in mind, yes, it does become significant when we have oligoarticular joint involvement. It will be covered up in the focus session. It's not a non-specific test, but more than 20% normal population may have ANA positivity at lower titers. So not non-specific, but may not be significant if your other clinical features are not corroborating. False positive, we do get if we are doing it by other means, and that is why we need to ask ANA by immunofluorescence to increase the sensitivity of this investigation.
Dr. Sunil, what is the best way to do an MT test in your experience, and how does one analyze it? Here it had come negative, so we don't even know how it was done, but can you just tell the audience?
Test is usually done for positive value in countries which have low prevalence and are not BCG vaccinated population. So value of MANTU is very effective in countries like India with a very high prevalence of TB and where every single person born is vaccinated with BCG. With that caveat, let's come to MANTU as a procedure. So you require something called as PPD. The ideal one which is prescribed by NTP, the RT23 is most of the times not available. Important thing is its storage is as crucial as a vaccine. So storage conditions are important. Once it is taken for
report
0.1 ml using a 27 gauge needle on a polar aspect of forearm, a small bill up to 5 to 7 millimeters is what an ideal MANTU looks like. And it needs to be read after 40 to 72 hours. The erythema part should be ignored and the duration should be taken into account, and something perpendicular to the vertical axis of the forearm is taken into measurement. Now the values for positive MANTU are variable, and second thing, at this age I would like to put a caveat, is the BCG vaccination if I am not wrong, right? Yes. So the values which are measured on duration needs to be taken in that context. So a BCG vaccinated child is likely to give a false positive MANTU if it is done relatively early in life. So if it is 16 to 18 months of age, I would keep that in mind that this positive response could be a...
How much millimeter is taken as a BCG response?
No. A value you said was 5 to 7 millimeter, something like that?
7 to 9.
7 to 9 millimeter. So if it is 10, only 1 millimeter, right? So there could be always an issue with measurement. So that is a fallacy of 1 to either. So anybody who is measuring, even if he makes a mistake of 1 millimeter, he would have gone into positive.
Positive, okay, fine, fine. Dr. Amol, in this situation when we are thinking of other diagnosis, when a MAN2 is negative, is it worth doing a IGRA? Whether in general?
Yes, because IGRA is like interferon gamma release assay, which will contain non-BCG like ESAT6 and CFP10 proteins, which are not there in BCG vaccine. So we can take it, but reading IGRA less than 2 year is little bit tricky. So considering the syndromic presentation which is fitting and IGRA positive, then we can.
So technically you mean to say IGRA has got more sensitivity in diagnosing TB over an MT?
Yes.
Right?
Can I ask?
Yeah, sure.
There is a new test, I mean, it is available now for C by TB. So can you kind of elaborate on that if you, because we are doing that regularly now at Jupiter. So C by TB is ESAT antigens. Would you like to say something about C by TB?
So IGRA is contained to like TB Gold Plus and only TB. So Gold Plus actually containing 3 antigens, ESAT, CPF and one more antigen. And there are 2 methods like T-spots and tube method. So generally tube method is more sensitive.
C by TB. So so C by TB is a cutaneous tuberculosis test which is using ISAT now 6. So it's more specific, and as Sunil was saying that the interference with BCG is not there. The positivity is 5 millimeters and above, as against Montauk's where it is 10 millimeters and above. And that's why in such a situation, I think C by TB and it's available. 900 rupees is the cost, so we should know about it.
I think we are available. Good, you brought up that point.
Thank you.
We are still in flashback. At 18 months, on base of above investigation, child was labeled as monoarticular GI. Initially, he was started on non-steroid anti-inflammatory drugs and oral steroid. As there was no improvement in swelling, then intra-articular steroid started and child visited thrice for these intra-articular steroids. As there was no improvement in joint swelling, child started having limping and having fever since 10 days of duration. 2 spikes in a day. However, parents have not recorded temperature, and temperature was responding to ibuprofen, and child was brought to my clinic. So on general examination, anthropometric, weight was 9.9 kg, which was less than 3rd centile, height 87 centimeter on 10th centile, and there was limb shortening on left side 1 centimeter. On general examination, BCG scar was present. There was no generalized lymphadenopathy, organomegaly, and spine was normal, and skin was, there were no any skin manifestations. On local examination, child was found to have cystic mobile swelling with fluctuating mass. There was no overlying scar or sinus, and joints movements were restricted. Respiratory system wise, it was clear, and per abdomen there was no organomegaly or any ascites.
So Dr. Sunil, what is your inference based on all this information, and what are the possible differential diagnoses that one can think of at this point in time?
After going through the entire information, see, the difference between me and some of the panelists and all of you is I am a teacher at heart. So I am not happy with the kind of history which is provided to me. The socio-economic history of this family, this child, would have helped immense, right? So there are clues in families also. So if we casually say there is no history of Fox contact, doesn't mean there is a family member who is suffering from. Now, coming to this examination, now the general examination, the anthropometry itself is very suggestive that this child is failing to thrive, right? So yes. Look at the parameters, he is failing to thrive. Now, though there is a BCG scar present and generalized lymphadenopathy, so it is not required because it is an isolated EPTB, which is a very important component of pediatric TB, and we are dealing with more of EPTBs than pulmonary, right? So, the family history, the socioeconomic history, the dietary history, and the story of that 1 year would add immensely, because we are looking at points in isolation or silos whereas this child is a member of a bigger family who has a environment or a milieu wherein there might be many other issues, right? So I think as a pediatrician dealing with possible infectious causes, we need to put this child into that milieu and look at, because he must have got this from one of the elders. It is not possible that he has got it from somewhere else. So I would have a very, very high index of suspicion in India, especially with the high prevalence of tuberculosis. In fact, I am criticized that I see TB in every patient. And I am very happy to be criticized for that. Because if me, as a pediatrician, end up missing a TB, the morbidity I will be living will be immense, right? So with that story, I think the earlier conviction I had that monoarticular for me at that age, ruling out other possible causes, still seems to be a septic arthritis. Amongst that, lacking the active inflammatory or infectious issues, it looks like an indolent TB monoarthritis for me.
Dr. Amol, what sort of investigation would you do at this point in time, and why would you do it?
So this child is presented with chronic complaints more than 1 year. So I would like to do some basic investigation like CBC, CRP, ESR, and then PTA, PTT, and other investigation, specific investigation if synovial fluid aspiration and testing for MTP, AFP, gene expert and MGIT culture, as well as MRI to know the details about the joints and the synovial fluid.
Workup done, which showed HB 10.9 gram, total count 11,600, volume was 54%, and platelet 2,23,000. ESR was 79, LDH was 283, bleeding clotting time, PT and APT were normal. Tuberculosis, Montux was done with 2 TU, which was strongly positive, 13 to 15 mm, and chest X-ray was absolutely normal. MRI done, so MRI showed moderate synovial effusion with synovial thickening, that is suggestive of synovitis, and other features like there were no features of suggestive osteomyelitis or bone erosion.
So again, back to experts. Amol, last time we just discussed ESR. So in this patient ESR came from 15 to 79. Is it how significant it is, and will it help?
Nowadays, ESR is mostly taken consideration into certain disorder only, like osteomyelitis or rheumatological disorder. Otherwise, it can be increased in anemia also. So, okay, the child is having chronic complaints, so we can take it as a significance.
What I mean to say, going up in ESR like a CRP, going up means an active disease,
yes,
or a progression of the disease. Can we analyze it that way?
Yeah, we can consider it as an active because if it is a chronic, it will not be that high.
Exactly. Ma'am, LDH was done in this patient. I'm sure you would like to comment on that. When actually an LDH is indicated to be done, what are the indications, and how does we go about interpreting it?
Yeah, so LDH in arthritis we generally don't do until and unless we are suspecting some complications like MAS, macrophage activation syndrome, or HLH, or malignancy. These things will increase the LDH levels, otherwise in arthritis we do not do. Just to add to the point of ESR, in 1 year, if you're telling me it's going from 15 to 79, I might even consider a recent infection associated with fever and everything that has come up, so rather than the
acute
same
and chronic
thing.
Problem.
Exactly. I would consider more of that.
Yeah, fine. So back to Sunil regarding the MT. So here they had specifically written a 2 TU. So you think initially probably they had not used it, so it came negative?
Let's say give them the benefit of doubt. That was also properly done. This is also properly done.
Okay, fine.
That was a borderline positive or negative. This is strongly positive, right? Now there is something about MANTU which needs to be taken into account. There is something called as booster effect. So if you are giving 2 sequential MANTUs, the second one may get a boosting from the earlier one.
Within how much gap does it?
It is usually said that 12 weeks to 18, so 3 months to 6 months. But there is a possibility like that. But this could be because of a delay in the conversion. So maybe it is quite possible that the earlier MANTU was done a little earlier in the course of the disease, and this is the proper time for this MANTU. So this is the properly converted MANTU. So this in the background of a history which tells me it might be tuberculosis, I would take this as a relevant and a significant finding.
Fine. Madam, we keep doing MRI in arthritis, and in acute arthritis, I'm sure it has got a lot of significance because it helps us diagnose osteomyelitis and septic arthritis. When it comes to chronic arthritis, does an MRI of a particular disease has a particular diagnostic feature that we see on MRI? We see XYZ, okay, it is a JIA, XYZ, it is SLE, or something like that. Can we analyze it that way?
So for normal rheumatological diseases, the picture that you showed, it glares at us. You don't need MRI to diagnose synovitis or effusion there. But you would need it to rule out the differentials like osteoid osteoma or a tumor inside the synovial cyst. Otherwise, I would not do MRI ever to just diagnose synovitis.
Fine. So findings remain the same, more or less, once based on that clinical picture.
Yeah, clinically you will be able to make out if there
and
is...
if an MRI is done, you would more or less expect that this is going to come.
This is going to come. You only to rule out this is not there, this is not there, this is not there.
Complications.
Not to diagnose.
Which complications generally are you talking about, like, frankly?
I'm talking about mainly that we see is osteoid osteoma, PVNS, it's a
so
tumor in the...
diagnosis.
Exactly.
Achha, not a complication.
No,
Fine.
no.
Okay, fine.
So gene expert done showed mycobacterium tuberculosis, and MGIT culture also showed acid-fast bacilli in good number. So story till date, aspiration of synovial fluid which showed acid-fast bacilli and gene expert was positive, rifampicin resistance not detected, pediatric infectious disease opinion sought out, and child was started on 4-drug AKT, and child was reoperated after 1 month of AKT for debridement, and currently child is having deformity and limb shortening. This was wound after debridement after 1 month of AKT. Any further testing required at this stage, looking at the wound which is not properly healing?
Dr. Amol?
So this child was having chronic complaints with, he was operated also and was not responding properly to the treatment and his wound was taking so much of time. We thought of it could be part of a primary immunodeficiency, because Mycobacterium tuberculosis is also one of the signature organism in chronic granulomatous disorder, CGD. So I sent a workup for lymphocyte subset analysis, DHR and NBT, and everything came negative, normal.
The complaints of joint pain, and so what is happening? I mean, is that non-healing skin ulcer enough to say that this is non-response?
Wound healing wise, he was not responding locally. The wound was this thing, because he was given some orthopedic this thing to keep his flexural deformity to this thing maintain. But otherwise his weight gain was present. There was no fever spike. So symptomatically he was improving, only the wound was taking so much of time. And
is that accepted? I mean, would you still call it as non-response?
Unlikely, sir, because if it is non-responding, then the child will, because it's extrapulmonary, the child will present with some other symptoms, some new findings, so which was not there.
So, I mean, the ulcer is the one that's not responding. So, could it be that it was not attended to properly, nutrition, local infection? Maybe that could have helped.
That could be the possibility.
Yeah, TB-wise child was improving. We take your point very well. But probably those tests were done to rule out if there is anything else we are missing. So that will ultimately, finally help us in curing the kid. Huh? Ulcer was how many days?
More than 1 month.
1 month.
Fine. Fine. So, so like we come to the almost nearing the end. So questions to the expert. Dr. Amol, you can just tell us in short. We know that knee is probably not the commonest site to get a bone and joint TB. So you could tell us what are the common sites, generally about AKT in bone and joints, how many drugs, duration, etc. Could you just summarize in short?
So most common site, if you ask me regarding the bone and joint, it could be pot spine, the spine, followed by, if you ask like osteoarticular arthritis, then hip will come first, followed by the knee. So in our case, the knee was the this thing. AKT will be given for 12 months in bone TB. It will be like all 4 drugs, rifampicin, isoniazid, ethambutol and pyrazinamide. So 2 months of intensive and 10 months of continuation phase.
Fine. And Dr. Sunil, we do see this, but I'm just asking you, since you told you see a lot of TBs. So secondary TB, like bone, joints, brain, etc., we do a normal X-ray, we do an X-ray chest. Very often it comes back normal. So how often have you seen that? And once, even in this case, it is normal. So exactly in this case, what could be the pathogenesis in which this patient ultimately got a TB knee?
It is very common. Actually, extrapulmonary TB is the norm for children, but as a pediatrician, it is our responsibility and duty under the National Tuberculosis Elimination Program to find out the primary and try and, if possible, in every single child, to isolate the organism. So microbiological confirmation of TB is a must under the program. So given that, in EPTBs, everyone tries to find out a primary. And we all know TB, the primary has to be in the lungs. But most of the times, the classic primary complex is not seen. So it is not very uncommon to have a direct presentation with the extrapulmonary TB, even CNS TB like TB meningoencephalitis, without a primary in the lung. So it's not rare. It is quite common. And as to in this patient, the possible pathogenesis, TB arthritis per se could be a direct invasion of the joint or a reactivation, like we used to say in Ponsets. Or otherwise, it could be a seeding of the bone via metaphysis when there was a tubercular bacteremia initially, right? Right. And then, curiously, if the epiphyses are open or not fused, it can go from the epiphyseal end to the, metaphyse, epiphysis and into the articular space, right? So here it is, in fact, I think there should not have been a deformity because it is only synovial thickening. There are no other morbid pathologies which are noticed on MRI. So unless and until there was erosion and lack of joint space significantly, there should not have been a shortening of the limb in this child. I am very surprised why it was there. So I think here it is reasonably prudent to postulate that it was a primary involvement of the joint.
Fine. Dr. Amol, TB PCR, the initial treating physicians had done a TB PCR, as we said, it had come negative. So what are the chances, why did it come negative? What do you feel?
So the TB PCR is very sensitive and specific test. But the reason it has come negative because the yield is very low in fluid, like pleural fluid, synovial fluid. So we can isolate only 10 to 15% of time it will be positive. It will be prudent, like at that time we have done a synovial biopsy along with histopathology that could give earlier this thing, like the 1 year period has gone, so that will give
I had kept a question of CB net versus 2 net, but I deleted it because of there won't be any time.
Okay.
So now there is some time. Can you just tell in short?
Yeah. So
what is CB net? What is 2 net?
So CB net is a cartridge based nucleic acid amplification test, and True net is like a indigenous they have made. It is battery operated. CBNAT will require like a continuous supply of electricity, where TrueNet can be used under NTP anywhere in the periphery. The main difference, CBNAT is more sensitive in respiratory samples, otherwise TrueNet is specific. The thing is that CBNAT simultaneously detect resistance as well as mycobacteria, where TrueNet is a two-stage step process, where early it detects first MTB, and second part in last 1 hour it will detect the resistance. So that is the only difference.
So yield-wise, which is better? Like sensitivity, specificity, just one line. What is better? Sensitivity?
CBNAT.
CBNAT is better. Fine. So last, both of you, Dr. Amol and Dr. Archana. So in the whole analysis, was this TB all the while? Hence, it was never monoarticular JI, how it was labeled initially, Or was it monoarticular JIA? Probably did not respond to oral and intraarticular steroids because baby did get few doses of oral followed by intraarticular steroids to begin with. But the steroids, as Dr. Sunil did mention, the TB gets reactivated. So did it reactivated actually a TB which was sitting there because of the initial seeding? What could have occurred?
Looking at the entire case, I would go with the second option most probably. See, all our initial investigations were normal, even ESR. In a child with failure to thrive because of COX, at least some evidence of ESR, which was 15 at that time, causing so much of deformity as limb length differences. In oligoarticular, I would like to say the affected limb is longer and not shorter. So we don't know exactly which was longer here. Because like Dr. Sunil said, there are no erosions. So if there's increased vascularity in a growing joint area, it becomes longer. And I think that is what we saw here. Later on, fever came up and ESR got up. Until that time, we had given steroids. So I really, and plus ANA is too positive. One thing I would surely do is an eye test here. Because a joint, monoarticular joint, ANA positive, you see uveitis, there's no other DD. TB, of course, is always there with all the diseases we see. That would be my analysis.
Amol?
So I think it could be TB since the start, but if the child has not response in a 2 to 3 months after giving a steroids, we definitely at that time it is we could given a second thought of the infection, and because of I think giving steroid that has triggered the TB, which has reactivated.
Can we just generalize, give a message to the audience that whenever you see a monoarticular chronic arthritis, rule out TB before actually labeling it as a monoarticular JIA. Can we do that? 100%.
Yeah, because in any case you have to first rule out the infection first and then the other diseases.
Agreed.
Yeah, please.
Tuberculosis is when there is a primary focus, and then subsequently years later when the immunity goes down, there is reactivation. This is not reactivation. This is tuberculous bacteria grew there. Probably they were there right in the beginning. So there is slight difference here. This is maybe you can call steroid precipitated TB.
That is what probably
not reactivation. So I think we should not use the term reactivation for this. Reactivation tuberculosis is totally different, and that is to contrast against primary tuberculosis, which is what is different.
I think Amol can add on that.
I think like sir is right, because primary tuberculosis will be like in back 1 to 2, 3 years, but when the immunity go down, it will get reactivated wherever the bacilli is present. But in this,
the local steroid can do that, isn't it? No.
Yes. So in this scenario, I think we have given a steroid, so that could be one of the aggravating factor, because steroid also the immunity will also goes down when you give a high dose.
And it could be masking the TB.
Unless bacteria are there in the joint, they would not get kind of reactivated. So
yeah, means if it is a possibacillary, means pediatric is always possibacillary, because of the steroids and this thing, the mite growth has increased and the number has been multiplied. Flare up. Yeah. Flare up. Yeah. So flare up. Yeah.
Fine. So now I call upon Dr. Archana Khan ma'am to give us a focus talk on arthritis demystifying, a puzzle to solve. I think most of the puzzles already we have solved, isn't it?
Then I would be on a time. Madam, just a question, if there is a time. How commonly you see a oligoarticular arthritis involving only a single joint?
Many a times. Oligoarthritis is less than 5 joints, but many times we get just monoarticular, and many times we get both together, tuberculosis with monoarticular. Yeah, commonly seen.
Dr. Archana, another question from my side here, Dr. Sunil. Here. Oligo and mono. Mono could be one of the oligo, but I think a recent trend in the literature has been to treat it as a separate entity, monoarticular, right? So even if sex predilection for mono is lesser for females as compared to oligo. Uveitis is much lesser accompanied with mono as compared to oligo. So I think there has been a recent trend to take mono in isolation from oligo, where we used to treat mono as a part of oligo. Am I right if I am saying this?
You are right in concept, because mono has a lot more differentials than more than one joint. The moment we see a second joint, we are assured, okay, we are dealing with something like JIA maybe. But if, like you're saying, it's mono, the differentials are many more, and that is why it goes
I
into
think what Sunil is trying to tell is that when we read up, understand mono, the algorithm is totally different than
Yes,
poly.
yes,
That's what,
but
in short.
mono is still a part of oligo.
Yeah, obviously,
Yeah.
by definition.
Somebody is moving the slides. Okay. Here I'm on a time bomb, so I'll go a little faster. We are dealing with tiny joints which need big attention. We will run through some practical approaches to tease out these differentials that we are talking about. And any child who comes to us with joint pain will broadly fall into either infections, most common, infection, post-infection, or reactive, rheumatological, and a very, very small group but most important differential malignancy which we have to rule out. And that is why we don't start steroids on children with joint pains till we reach a diagnosis. Lucky for us, history and examination, like we saw in this case, leads us to a very good clinical diagnosis, and laboratories do not play such a big role as we generally think. And basically, if we focus on 5 questions and try to answer that, you would have crossed more than half the path. Is it arthritis? We have already covered it in panel. I will skip this. If arthritis, is it inflammatory or non-inflammatory? All inflammatory joints mostly have morning stiffness, pain, gelling after rest like we saw with raised ESR and CRP. Remember, a child who wakes up at night crying of joint pains, please don't classify it as JIA or inflammatory only. You need to take quick action on these children. Now you have a child with inflammatory arthritis. You need to know whether it is acute or chronic, because similar complaints, different durations, different differentials, different diagnosis, and you may reach to the diagnosis even on your history. What is acute? Less than 6 weeks duration. What is chronic? More than 6 weeks. What are the differentials you will think? Dr. Sunil or Amul, I think, has already covered it. But generally, acute conditions, you will not diagnose GIA until and unless you're dealing with SGIA or connective tissue diseases. Most of the times, it would be infection, trauma, coagulopathy, and other differentials that we've already dealt with. Do not diagnose GIA till you cross 6 weeks, or indolent infections like we saw in the earlier case. Very important to know, is it monoarticular or polyarticular, which is generally a clinical diagnosis. You have to meticulously look if any other joint is involved. This list is not to overwhelm. I will pause here for everyone to take a picture, because this is the chart you will revisit when an inflammatory joint child comes with acute or chronic presentation, and after you have differentiated whether it is mono or poly. Once you know these conditions, you come to the examination part, and you have to know whether your child is having only joint problems or he or she is suffering from a multisystemic disease. And this is where a clinical acumen from PJ Mehta comes in. Top to toe investigations. I've put in very few pictures just to highlight that these are the clinical clues that could lead to you to a diagnosis. You don't really need to investigate these children thoroughly for diagnosis. The telltale sign, malar rash, palatal ulcer. This child had actually come to us with Flicton, the eye child, and she was being treated for JIA. The diagnosis was a giveaway. IBD, the salmon rash of in the body, which is evanescent. You couple it up with quotidian fever, you have the diagnosis in hand. Try to look at simple features like nails for psoriatic pits, gangrenous toes, evidence of thrombus sitting somewhere, the type of ulcers that are there. So your history and examination itself will lead you to 80% of your journey. Another interesting chart coming up for children with more than 6 weeks duration. Joints alone, it is the JIA. Most of our children who come to us are diagnosed as JIA, but today you will be much wiser because you know this is joints alone. And if it is with systemic involvement, it is connective tissue disease or vasculitis or the systemic JIA only. Further investigation will lead you to the differentials. Again, I would urge you to just click a picture. I don't have time to discuss the differentials, but you will find it handy in future. The most important slide of today, will you do ANA in all arthritis? No. Only if you suspect connective tissue disease to diagnose or classify. A JIA child, you will do ANA only to see for susceptibility to uveitis. Most important, an oligo child of ANA positive, even when the joints are clear, I will still keep on monitoring that child lifelong because there could be silent uveitis that comes up anytime. And the JIAs that we generally talk about, child with joints, JIA, that is not the case. They have a very set pattern, and if you do not follow this pattern and the child is not following here, you're not dealing with JIA. I will give you very quickly a few patterned behavior. Remember, there's minimal constitutional features and remarkable lack of extra-articular features in JIA. A 4-year-old child, 1 hip joint, short duration, patterned behavior, reactive arthritis. A 3-year-old child, 2 knee joints, no multisystemic, more than 6 weeks, you're mostly dealing with oligo. Do not forget to take care of the eye. Polyarticular older child, more than 5 joints. This is the only child where you will do RF positive or negative, not in other JIAs. I will run through it. You will hit the panic button if it's not improving. SJIA mimics. These days we are getting leukemias and Kawasaki. And I will end my presentation. This child was got to me 3 months back. How do I stop this? Sorry, this child came to me 3 months back. With the cry, you know that it is not JIA now. 3 weeks he was ready to go to school. I stopped all NSAIDs, gave the child high dose vitamin C. This was a child of scurvy. And this is the crux of what I've spoken today. Look at other things and then diagnose JIA. Thank you.
Madam, just in short, like, if you don't mind.
Yes.
So, another test that I didn't put this in the slide, but because of time and relevance, I did not. So, ASO is another test we do as practicing pediatrician whenever we see, say, arthralgias.
Yeah.
So, ASO positivity in an arthralgia could be, we all know, rheumatic fever or a post-streptococcal reactive arthritis.
Yeah.
So, for a practicing pediatrician, can you just give a tip how to differentiate both?
Yes, so ASA does become important, especially these days we are seeing a surge of post-streptococcal. I would give significance to a rising titer still, or if it is accompanied by clinical features of rashes, pharyngitis and arthritis. There are a lot of positive, negative, and so I'm not going to diagnose arthritis or arthralgia based on ASA alone.
ASO.
ASO alone until and unless I see a rising titer or a gamut of clinical symptoms there.
Good morning, ma'am.
Good morning,
I think
Rachna.
Archana ma'am has very beautifully summarized the whole diagnosis of JIA. So I think what we need to emphasize is that JIA is a diagnosis which is purely based on your clinical acumen and not on the blood test. Because ANA is so frequently done and it can be quite confusing unless we have a very high pre-test probability that we are thinking of an autoimmune disease. Just to add to the discussion, whenever we see a monoarticular arthritis, 4 things that one must in their office practice rule out. First, tuberculosis. Second, hemophilia, especially if it's a boy coming with a single joint involvement. Third is PVNS, which is pigmented villonodular synovitis, which can be diagnosed on MRI. And it very much looks like oligoarthritis, and the last, when you have ruled out everything else, is when oligoarthritis comes in. And the use of steroids, and even in a monoarticular arthritis, a rheumatologist will always wait. Start with naproxen, consider giving local steroids as by doing a joint aspiration, because that itself gives you a lot of clue to the diagnosis. If there is a hemorrhagic fluid coming, we often think away from oligoarthritis and consider the other diagnosis. And obviously you can do a TB test in such situations. So whenever there is a monoarticular arthritis, I think we must be very, very careful in diagnosing oligoarthritis in such situations.
Thank you.
Correct. The JIA is idiopathic. Rule out other things and then label the JIA.
Yeah, thank you.
Thank you for sharing your knowledge, dear faculty, and for insights and expertise that will make an impact. Now I request the dignitaries on the stage to please proceed to the felicitation point. Thank you. There is small announcement and a request. Due to time constraint, now chits will be distributed amongst audience. If anybody has any question, please write it on paper and give it to one of us. Now we'll proceed with our second session, that is striking a chord with gut bleeds. I would like to call upon our moderators, Dr. Sonali Mane ma'am, Dr. Pooja Thakur ma'am, and our respected panelists, Dr. Dimple Jain ma'am, Dr. Shivaji Mane sir, and Dr. Rehan sir.
Good morning, everyone. Good morning to all our esteemed panelists. Let's start the discussion. Striking a chord with gut bleeds. This is a ABC 1 year 11-month-old male child. History of cough, cold and fever since 15 days. Cough and cold since 15 days. Fever since the last 6 days. Breathless since 3 days. He was already treated as bronchopneumonia for 7 days in another hospital, which was detected as mycoplasma positive there. On day 7 of hospitalization, the child got better. He was almost going to be discharged when he had blood in stools. The stools continued to have blood for 3 days. Initially it was black tarry, but later it turned fresh. On day 10, there was one episode of non-projectile, non-bilious vomiting, which was mixed with a single blood clot. And also the same day, there was one episode of convulsion in the form of GTC, lasting for 1 minute with postictal drowsiness. At that point, the child had severe pallor, tachycardia. He was normotensive, but there was a severe drop in HB from 11.7 to 5, and so the child was referred to tertiary care hospital. So continuing in the tertiary care hospital in the casualty, the child had one episode of bleeding PR, which was fresh blood at that time. In the casualty, the child was stabilized on oxygen. On examination, he was conscious, oriented. He had a sick look. He was a well-grown child. There was severe pallor with a heart rate of 180, respiratory rate of 28. Saturation was 94% on NRM. CRT was 3 seconds. The blood pressure was 94/56, which was normal. Systemic examination per abdomen was soft. There was no distension, no lump. Respiratory system examination was normal. There was no distress. And the growth chart was normal. The child was well grown. So around 25th to 50th centile on weight and height. So what are the thoughts on history? Dr. Rehan, can you please elaborate?
Hello. Good morning, everybody. As you go through the history, initially the patient came with cough for 15 days. And then the fever started on probably 9th day of the cough, probably. So we are dealing with a bacterial infection rather than a viral infection. Because if it was a viral infection, I would have expected to, settle down within 5 to 6 days' time. It could have been a viral going into a bacterial. That is the first thoughts on this history. Now this child became breathless and was treated for bronchopneumonia, and we have a diagnosis where we have a mycoplasma positive. So we are dealing with a mycoplasma pneumonia which was there. Go to the next slide then. Yeah. So as you go ahead, then the twist comes in the case. Here you have a discharge that is bleeding, and that is black tarry. So we are dealing with something which is probably an upper GIT bleed. Now there was a history of vomiting which was non-bilious, non-projectile. Okay. There is history of convulsions. Now, if you try to correlate this convulsion with all this history pattern, few things come to my mind. One, it could be mycoplasma causing the encephalitis, or probably a focus which was there, which was stimulated because of the stress. But most probably a mycoplasma causing this. And when you look into this thing now, you have to decide whether we are dealing with an upper GIT bleed or a lower GIT bleed, because then only you can proceed further with this case. Now, initially it is basically a mycoplasma, and now you're coming up with a bleeding in the stomach. So I would like to rule out these causes on history part. So how would I rule out? Now, what are the commonest cause of upper GI bleeds? Stress bleeding, because this child was suffering from respiratory disease, pneumonia. So first thing which comes to my mind is a stress bleed. But I would not have a torrential bleed in the stress bleeding, because the child had a fresh blood in the stools after the initially when there was a upper GI bleed. Always will be something like you'll have melena, but you'll not have fresh blood. So there was a bleeding which started slowly, and it was a torrential bleed. So then I have to look at that part, because the torrential bleeds were there. So I would rule out stress bleeding. Malarial is less likely, because this child basically had only one vomit, but unless you have a case where you have a gastroesophageal tear, that is the only condition in malarial when you can have a torrential bleed. But less likely in this child where you are having a malarial causing this. Then you come to protein allergies, that is cow's milk protein allergy. There is no history which is suggestive. The child was on top feeds and all that. And again, if you have a protein allergy, I would ask few questions on history, which were not included in this. So first thing I would ask, there are any hives, there is any diarrhea, there is any fever. So if this was not there, I would like to, and I would not expect a big bleed, in a patient of having a protein allergies. So again, that is ruled out. Few questions again I would like to ask in the history to rule out other causes, like any rashes below the buttocks, or any abdominal pain which was there, or you have a urinary tract infection, to rule out purpuras. And ecchymosis. If there were ecchymosis, I would look into bleeding disorders. So that also, the history is not there. I presume it was negative, because you have not mentioned in the history. So I presume there were no bleeding disorders. So again, that is also ruled out. So now I'm boiling down to my diagnosis slowly and steadily with various history part. Now, other than this, what are the other causes which I can think of for an upper GI bleed when I've ruled out all this in history? So peptic ulcer disease I could think of in this child. So now, what are the signs which will tell me that this could
So
be
let's go ahead and see how the story unfolds.
Sure, okay.
So I would like to, sir mentioned, we need to first distinguish whether it is upper GI or lower GI bleed. So, Dr. Dimple, can you please let us know how do we distinguish on history or examination?
So in this child, our first thing that we want to know the source, the site of bleed, whether it's an upper GI or lower GI. Upper GI means above the ligament of Treves, and lower GI is below that. So if it's an upper GI bleed, it can present with hematemesis. The black tarry stools can go in favor of an upper GI bleed, because it is because of the acid hematin that is formed. And if it's lower GI bleed, you can get either frank blood or you can get maroon colored stools. So that is our primary this thing.
Right. What would be the red flag signs which we'll look for in any child?
So red flags is massive hematemesis. So a hemoglobin drop of more than 2 g%, tachycardia more than 10% of the baseline. If there is hypotension, if the child is in shock basically, then these are the red flags. Or if you have any signs of obstruction, if the child is crying excessively and the child is having bleed PR, I'll be very worried, because it will be an emergent surgical cause like an intussusception, a volvulus. These are all the red flags.
We actually already discussed, but Rehan sir, what do you think is the etiology in this case at present, just on the history, that you already actually elaborated most of the things?
Yeah, when you look into the history, we are boiling down to few things. Now it is sure that we are dealing with the upper GIT bleed, that's for sure. Now with this, we have few things where you can have an upper GI bleed. So peptic ulcer disease would be one of the things which will come to my mind, along with this whatever respiratory problem the patient had. And I have to read that diagnosis before going into invasive this thing. So for that, I would like to do only one test, and that would be a gastrin test. If I have a gastrin which is high, I would look into there is a peptic ulcer disease, probably one of the reasons for that. So that is how I will proceed. That would be my first, one of the differentials in this. And that could be the cause of this bleed coming up in this case.
So here I'd like to add, here the history that we have is black tarry stools on retrospect. The parents are telling that there were black tarry stools, but when the child came to us, you mentioned that there
Fresh
was
blood.
fresh blood which was there. So we need to take it with a pinch of salt, one, and such massive bleed. Whenever there is such a massive bleed in a child who is less than 2 years old, plus minus, we're not sure of the black tarry stools, that one clot in the vomitus, I would still consider Meckel's diverticulum. So any child less than 2 years with a massive GI bleed, with an HB drop from 11 to 5, Meckel's is one thing that I would really consider. Other thing would be if there are esophageal varices. Even so, whenever there is a hemodynamic instability in an upper GI bleed, varices is our first differential, even if we don't get a spleen which is palpable, because after an acute bleed and a massive bleed, the spleen can sometimes shrink. So we need an USG Doppler for that. So,
just one clinical point. That you mentioned that there is a history of the small clot in the vomiting. Normally, none of the pathology except the upper GI will have a blood in the vomitus. Meckel's will never get a blood in the vomitus unless, I mean, it is impossible to get a Meckel's with a blood in the vomitus. So I will definitely, at least I will not agree with Madam, Meckel's could be, though it is one of the commonest cause, more than 50% of cases of the GI bleed is because of Meckel's in this age group. But having a blood in the vomitus, it definitely rules out the Meckel's, it doesn't signify that. Most of us who believe that probably melena indicates the bleeding from the upper GI, and having a fresh blood or something like a maroon color blood probably indicates the distal GI bleed. But if you read very carefully, most of the books mentions that if there is a special massive bleed, which is there in this particular child, there is always a cathartic effect of the blood in the intestine itself and can produce effect like having a fresh blood in the stool. So just because of having the fresh blood doesn't mean it is not upper GI bleed. It is, if the massive one, it is possible. Similarly, if the child is having a, say, small intestinal bleed like a Meckel's, still can have something like a Mullen effect, purely because if the intestine sometimes transit time is slow, activity is less, one can still have a black color stool in the, even in the Meckel's. So one should not go totally looking into the color of the stool, though largely it suggests, but that doesn't mean confirms it is the upper or lower GI.
Right, sir.
As a pediatrician, I would put in an nasogastric tube when he comes to me, and if I get the coffee-colored aspirates, I would still think of that it is a upper GI bleed.
Yes. We go ahead with the investigations. So before the child was transfused, we have a hemoglobin of 5, WBC of 14,500, which is predominantly neutrophilic, platelets of 2,19,000. The PT-INR was deranged with a PT of 15.3 and INR of 1.45. The PTT was more than 180. Electrolytes and creat were normal. After transfusion and of course giving vitamin K, the hemoglobin stepped up to 9.8 with a normal PT-INR and PTT. We also did a factor 8 levels and fibrinogen. So factor 8 was normal, fibrinogen was low. Which investigation would we do next, Dr. Rehan?
Having seen this, go back to the previous one. Yeah, having seen these investigations, now we know that there is a bleeding which is occurring, that is why the fibrinogen is being used up, and therefore this confirms that there is a massive bleed and the child is going into a bad shape. So the other investigation, as I said earlier, I would like to do a gastrin test, because that will really help me in finding out. If the gastrin is extremely high, then I would look into Zollinger-Ellison. If it is moderately high or just above the normal levels, I would think of a peptic ulcer disease. That would be my investigation further. Other than that, I would like to go for a USG. USG would really help me. Because what happens in USG, can have a normal USG, we can show you some findings, and especially a Doppler USG. A Doppler USG can show me if there's any ulceration there, in spotting there. So that could help me in the investigation part. And other than that, we go for OGD scopy, which I would like Madam Vogara to mention on that, because she's dealing with this regularly.
So I would like to ask Mane sir, what one should look for in the USG? from surgical
Depending upon what age you are subjecting the child for sonography. But suppose you are doing a sonography for a child, say, below 1 month of age, probably one of the common cause remains something like a malrotation, if the distal GI bleed, obviously not for the hematemesis. So look for the whirlpool side. If it's little older child, above age of 2 to 5 years of age, probably esophageal varices, we look for the portal anomalies. If the portal cavernoma is formed, there is a splenomegaly, or something related with the, if the do with the color Doppler, probably we'll see the reverse of the flow. And most important remains is the older patients, something like some duplication cyst is also one of the cause for the distal, GI bleed. So these are the few things that we commonly see with on sonography.
So, if the USG findings are normal, I would like to ask Dimple ma'am, so should we go ahead with a CT angio or any other investigation?
So, here, when our differential is probably an upper GI bleed, if the child is stabilized, then of course the first thing would be to go ahead with a gastroscopy. If the child is not stable, the child is unstable, then till the child is hemodynamically stable, we do not generally go ahead with a invasive procedure. So first is CT angiography or a Meckel's scan if possible, because Meckel's is also one of the differential that we consider. CT angiography will help us in multiple ways to know the site of the bleed. And since this child was actively bleeding at that time, so if you have a bleed of up to 0.5 ml per minute also, then a CT angio can tell us the exact site of bleed. So if we do not have a radionuclide scan available with us, and if we find out that the bleeding is from the distal ileum or from the mid-jejunum, then our differentials change. Or is it from the duodenum? So as Sir said rightly, duplication cyst is a very, not very common, but it's one of the sinister things which can present. It can present with multiple ways. It can present with intestinal obstruction, just chronic abdominal pain, and even GI bleed is one of the common presentations of a duplication cyst.
So in as in this case, when the patient was having black tarry stool and also there was a history of fresh bleed, so whether one should go ahead with the upper GI scopy first or lower GI scopy?
Upper GI scopy. So once the patient is stabilized, then a gastroscopy is to be done.
So in this case, ma'am, it's okay, but otherwise also, what is the first line, or would you do both together in one sitting?
No, so not both together if we get the etiology. So if the patient is stable, so if the patient has stopped bleeding, we've given him a transfusion, the patient is stable, hemodynamically stable, then we take him in for a gastroscopy, because at the same time we can make a diagnosis and we can treat it. But if the patient is hemodynamically unstable, and meanwhile there could have been a surgical cause, and you do not want to wait to do an upper GI scopy, you can do a CT angio. So simultaneous test. Plus a nasogastric tube will tell us, as Rehan sir rightly mentioned, you put in a nasogastric tube, give a wash, see if there is a bleed from the stomach which is there, which will help you more.
Okay. Is there any role of capsule endoscopy in this patient?
I think.
So you can. So capsules are generally large. In a 2-year-old will not be able to swallow the capsule. The minimum size is almost 2.5 to 3 centimeters. So not really. It's only after we do all the other tests, and if we are really not able to, the role of capsule comes in a small bowel bleed. And it's more in likely in obscure occult bleed, where we are not able to find the source, but otherwise there's no role.
Okay. So in our patient, USG abdomen was normal. CT angio showed hypertense intraluminal contents involving duodenum, proximal jejunal loops. It was noted in a portovenous and delayed phases, suggestive of possible contrast extravasation. There was no focal thickening or mass on that study. So this is the child was posted for upper GI scopy on the next day. After stabilizing. On scopy, there was a large deep ulcer at the first segment of the duodenum with slough mucosa. There was no active bleeding from the ulcer. Second part of the duodenum was normal, and the biopsy was taken from the first part of duodenum and antrum. So any other further investigation you would like to do?
So this came as a shocker. So having a large ulcer in the duodenum in a child. Anyway, that it stopped bleeding. So there is a Forest classification for duodenal ulcers, where we see whether there is any visible vessel, whether there is any adherent clot, whether there is active bleeding, which have a very high chance of rebleeding. So wherein we go ahead and do an intervention. Now, since this ulcer was completely quiet, it was best left untouched, and that time we take biopsies to look for other causes. one is H. pylori is a the most common reason for peptic ulcer disease is H. pylori. So we need to take multiple biopsies from the stomach, and we also took a biopsy from the D1 to look for anything else which could be there. On a biopsy, histopathology can take approximately 48 hours to come. So meanwhile, we do a spot test in the endoscopy room itself, where we take a biopsy from the antrum and we plant it on a rapid urease test. So it's a slide which is, which has urea and agent like a phenolphthalein. So H. pylori is a urease producing organism. So it breaks down the urea and produces ammonia, makes the system alkaline. And in the alkaline medium, phenolphthalein will turn red. So that's an indicator which we use. So that is a way rapid. So it can help in the diagnosis of H. pylori, the rapid urease test.
As a pediatrician practicing in Bhiwandi, first I would be doing a breath urease test, because that is non-invasive, before I refer to Dimple for further management of scopies and all that. And breath urease test for this child below 2 years, we can take with little caution, because normally above 6 years, these reports are normally, they are taken properly. So I would like to do a breath urease test. If that is positive, so I'll think about a peptic ulcer disease, and then the further management can go ahead with it. Because here you have to take a biopsy, and for that you have to do a scopy for the rapid urease test.
Which is more specific? Breath
Rapid urease test is more specific. But then I don't want to be invasive at my place when I'm working in my hospital there, so I would first start with that.
So in this case, rapid urease test was positive. I would like to ask Rehan sir again, is there any association of mycoplasma and H. pylori with this?
This is a very interesting thing. And one important feature of mycoplasma and H. pylori, they use up cholesterol from the cells, and that weakens the cell wall. And therefore, there are high chances when you have two organisms like mycoplasma and H. pylori, the H. pylori becomes more virulent and it enters the cells. And probably that was one of the cause of this child of mycoplasma landing up with huge bleeding and ulceration in the duodenum. That is one possibility. Again, one more feature of both the organisms is that the TLR6, that is the inflammatory marker, which both these organisms are, stimulates them. And probably that is why this H. pylori became more virulent. And that may be the reason that we have an mycoplasma pneumonia land up with a ulceration, probably.
APTT was extremely high in this child before blood transfusion.
Probably
So
it
how do you
was
interpret that?
slightly like a DIC like picture got corrected after vitamin K. It's because of massive bleeding most likely, or it could be a lab error.
Probably. I think
Yes.
because the platelet count was normal.
Because it
so
immediately
in
normalized.
DIC it is
Yeah.
less likely. Or are we having any underlying, that's what you think? I mean,
No,
with
the
such a high APTT.
further
Correct.
tests were normals.
But that was after transfusion.
That was the only single test which showed high PTT.
Correct.
Dimple ma'am, what should be the treatment of H. pylori, and how long we should continue that?
Yeah, so there are multiple ways in which H. pylori can be treated. One is a triple drug therapy is recommended. So you can either give a 2-week course of 3 drugs. So PPI is common in all, amoxicillin is common. So you can give PPI, amoxicillin and clarithromycin for 15 days. Or in places where there could be clarithromycin resistance, you can give PPI, amoxicillin and metronidazole for 15 days. Now, H. pylori is a very fastidious organism, so very difficult to culture, very difficult to find out the drug resistance pattern. So one more way of treating H. pylori is where we use all the 4 drugs. So this is called as a sequential therapy, in which we use PPI, amoxicillin and clarithromycin for the first 5 days, followed by PPI, amoxicillin and metronidazole for the next 5 days. And then there are, for resistant treatment, if the child does not even respond to that and you repeat a urea breath test and it's still positive, then you can add bismuth or you can use further higher doses of amoxicillin.
So the child was started after scopy on amoxicillin, clarithromycin, metronidazole and pantoprazole. Patient was hemodynamically stable and hemoglobin level was maintained through, though he had a mild melena. After 2 days, again he had fresh blood in stool. So for that, child again posted for second upper GI scopy after 2 days. On scopy, there was a large ulcer at D1 with adherent clot was there on the ulcer, which later started spotting. It was not possible to clip that time, so organ plasma coagulation was done along with the injection adrenaline was given, and then bleeding was controlled. Ferrocrylene glue was applied over the ulcer. So this is the picture where you can see the blood clot over the ulcer. In second picture, you can see after bleeding control. This is this short video where you can see the spurting vessel. So these are the post scopy after controlling the bleeding. These are the pictures.
So actually, this child had a very big ulcer in a very small child, both the things. So for the routine hemoclips that we apply, so this ulcer, we need to take the fresh edges. So it was far beyond the fresh edges of the hemoclip. Other thing that we could have done, if it was a slightly older child, even if it was a 4 or 5 year old, we could have done a over the scope clip. But this less than 15 kg child, it's very, very difficult. It will not pass through the...
So after second scopy, child was better. There was no repeat fresh blood in the stool. However, after 5 days, again he had frank hematomesis with massive drop of hemoglobin to 4. So should we call it as a failure of medical management?
Yes, so that is the way it will go. First is endoscopic pantoprazole infusion. With that not control, endoscopic management. With that not control, it has to go into two things, either a surgery, or if it's an older child or an adult, they generally go for radiographic embolization of the gastroduodenal artery. But in children, I think surgery is more better.
So I would like to ask Mani sir, what should be the next line of management after this failure of medical?
The next time, when I received the call for this particular child, the next thing that we did was putting the riles tube, given a stomach wash to stabilize, to clean whatever it is possible. And immediately, obviously, the child, he would have drop of hemoglobin from almost to 4 gram, right?
4.
So I think it was an indication to go for a surgery. Now, what surgery that one can do it? Of course, first thing is to suture control the bleeding. And when you open the duodenum, first thing that we did is open the duodenum entry wall longitudinally, starting from the pylorus. And we could see the ulcer on the first part. Do you have the photo, a picture? So what you see on the first photo, that was ulcer, and the center, the arrow which shows, that was a bleeding gastroduodenal artery, end of the gastroduodenal artery. And obviously, when I started to just hold the tip of the artery with the forceps, it again started severely bleeding. Again, I just could not do anything except I took a gauze of adrenaline, put it on that, gave a pressure for almost 10 minutes. Once the bleeding started, then I realized it is not possible to just take something like a quatrazole bidder. So then I took a multiple suturing of that ulcer, taking the vessel in that along with that. And so this is what you see, the black thing is non-absorbable, so that is the mersilk, taken interrupted sutures, and then we could achieve the control the bleeding. Another way is to go outside the duodenum and ligate the gastroduodenal artery from outside. But technically, sometimes it may be challenging because one can damage the common hepatic duct. So best thing is to go for intraluminally. At the same time, we extended the incision more proximally across the pylorus, and something like what we achieve is the pyloroplasty. Now the next question remains, that is what you see in the next photograph. That was the pyloroplasty. This was the second photo, shows that is a highly selective vagotomy. What is the role of highly selective vagotomy? In fact, today, with the era of where we can 100% achieve the control of the H. pylori treatment with antibiotics and other so many drugs, but still there are cases, especially patients who have got a peptic ulcer disease with complications like a hemorrhage, severe hemorrhage like this, sometimes perforations, and third is sometimes a stricture. Now, all these cases require a surgical intervention in the form of either we go for the drainage procedure along with the vagotomy. When you do a truncal vagotomy, the chances that child's overall growth rate can be hampered. So best thing is to go for a very highly selective vagotomy. That is what we did along the lesser curvature. You ligate all possible vessels, small vessels going towards the stomach, and this is what you see in the photograph. And we ligate all the vessels along with the nose, branches of the vagus nerves. So that is what you call the highly selective vagotomy. I can confess that I have done this first surgery after my 35 years after general surgery. That is after general surgery where I didn't have vagotomy. And this is the first child we had done a vagotomy with a pyloroplasty for a peptic ulcer disease in a small age, because we hardly got any indications in otherwise a pediatric age group. And as I said, indications remains is because you can just ligate the vessel and you can leave the suture the duodenum. But whatever the literature says, which at least at that time, of course, I was not very aware of that. Subsequently, I realized there is a high incidence of recurrence of the disease because of H. pylori itself, can similar complications. And the mortality reported to be because of upper GI bleed, not only because of the H. pylori, is also almost in range of 10%. Even a mortality of 10% is quite a significant, H. pylori disease because of recurrence for disease. So there is a role of doing a vagotomy, highly selective vagotomy, and in fact, highly selective vagotomy doesn't require a drainage procedure. But since you open the duodenum longitudinally, we have to suture it transversely.
So I would like to ask Rehan sir, in office practice, what are the pointers to refer a child for endoscopy?
As we just discussed through the history part, if we are clear with our history, we almost boil down to few things. But when you are sure that you want to do an endoscopy, few things. If a patient has dysphagia, or you're suspecting esophageal varices, you're suspecting some bleeds which are there in the stomach which could roll out AV malformations or other bleeding disorders, peptic ulcer disease, then in certain cases when like ulceration, so at least you can diagnose whether there are any, what exactly is the cause of these bleeds. And also for the treatment part, endoscopy can be done for the treatment part. As Madam rightly mentioned that we need to ligate this and get this ulcerations first tried with the endoscopy. If it doesn't respond, then you go for the surgical part. So the endoscopy is really a thing which really helps in certain situations.
Thank you very much, Dr. Rehan, Dr. Mane, and Dr. Dimple. I request Dr. Mane sir to further enlighten us about the bleeding PR in children. How many days or what is the duration of H. pylori therapy? 2 weeks or 10 days?
So if you're giving only 3 drugs, so amoxicillin with clarithromycin with PPI, then 15 days.
And
if you're doing sequential therapy, then 10 days, 5 plus 5.
Another question, children reporting with repeat episodes of vomiting, like if it is suggestive of gastritis, can we do a breath test or scopy after?
So there are these children who tend to vomit, very frequently, and frequently they'll be coming that, there is vomiting, and you know that there is generally no other cause. You've ruled out the surgical causes, you've ruled out anything, metabolic also. So can we make it a practice that in these children, at least this breath test, if it is non-invasive, can be done to think of H. pylori? Because I'm not sure what is the incidence really in our country of H. pylori infection, if there are any studies.
So one is H. pylori is very common. So carrier state of H. pylori is, if we see literature, up to 5 to 8 years, it's 50%, and in adolescents, it's as high as 80%. So 80% are carrying H. pylori because it's a fecal-oral route, and everybody is eating outside, hygiene is poor. So it's very, very common. But whether it is a cause of symptoms, it's not known. If you see, there are multiple meta-analyses which still refute that recurrent abdominal pain can be associated with H. pylori. There is no clear-cut indication. But having said that, we have found children with recurrent abdominal pain. We have not found anything else, only found H. pylori, treated it, and the child has responded. So it's only a matter of literature has to show that. About your other question, whether we can do a breath test, yes. So for diagnosing H. pylori, there are multiple ways. You can do a stool antigen test. You can do antibodies in the serum, which may not suggest an acute infection. You can do a urea breath test, or you can do an endoscopy where you can do a rapid urease breath test, and you can demonstrate the organism on histopathology. So all these 5, they have various sensitivities and specificities. Urea breath test you can do. The only downside why we would suggest that go ahead with an endoscopy is when you're doing an endoscopy, you're not doing it to diagnose H. pylori, but you're doing it to look for other causes which may be the cause of the recurrent abdominal pain and vomiting. There could be a lax GE junction, there could be mild achalasia, there could be a gastritis, duodenal ulcer, there could be multiple other reasons. So that is why. Otherwise, if you are strongly suspecting only H. pylori, even a breath test is good.
We'll continue with sir's presentation and take up the questions. Either put it in the common group or ask ma'am during the lunch break. Thank you so much.
I'm going to present one more case of the bleeding pair. This was a 1-year-old girl presented with the bleeding pair for 2 days, presented with the pediatrician, a practicing pediatrician. He had his child also had a history of vomiting, which was non-bilious. I mean, it was just mainly containing the food particles that the child had. History of mild cough for 5 days, and child was otherwise comfortable child. And this was referred to the sonologist, one of the good sonologists from Thane, by pediatrician. And the report was intussusception, ileocolic. And then the patient was, this was done around 3 o'clock in the afternoon. Immediately the child was referred to me in the OPD at 4 o'clock. And when I talked to the radiologist, he says there is a ileocolic intussusception that I could see, and it got reduced the time of the end of the procedure. So, any comment from the audience or anybody? Dr. Dimple? No. So, basically the intussusception from the history itself. A child who presented the history of bleeding PR for 2 days, and the sonography says the intussusception, which was ileocolic, getting spontaneously reduced. It was difficult to believe for me. As a surgeon, we have seen many cases of intussusception. And normally when you see a child coming with a bleeding PR, usually there is a history of more than 24 to 48 hours, which means there is too much of pressure on the mesentery of the intestine, and there is a lot of congestion of the vessels, and there is a lot of edema of the intestinal mucosa. And that intussusception getting reduced is next to impossible to believe that. The transient intussusceptions are known to come and go. It can get reduced spontaneously, and those are the intussusception will never come present with a bleeding pair. So this was the most technical point, rather the important point as a surgeon, which I felt it is unlikely to be the cause of the bleeding pairs as an intussusception. So, as you know, this is a typical that intussusception is an intussusception, that is what receives, and this is the intussusception what goes inside the bowel. And this is the mesentery which also goes inside, produces a pressure effect on the mesentery, congestion of the vessels, edema of the mucosa, and subsequently after, initially gets a congestion, leads to some blood, which blood usually is in the form of like a small blood, which is a mucus mix, is a red current that's classically described as. And what you saw in this particular child was a large blood like this. And this was unlikely to be, again, we get with the intussusception such a large blood. And so it was the most important that I remember. It is unlikely that intussusception can have such a large bleed. And second is unlikely that intussusception coming as a bleeding pair, getting spontaneously reduced was difficult to digest that. So with this, the next thing, obviously, again, one has to be very careful. When I saw the baby in the OPD, clinical findings, the child has no distension abdomen, absolutely stable child, pulse rate was good, volume was good, there was a minimal pallor, and abdomen was absolutely soft. I could not feel any lump anywhere. But still, I had not to miss the child anything pathologically, so I immediately took the X-ray abdomen to just to see whether the fluid levels are there or not, even though the child didn't have that particular day any vomiting. X-ray was absolutely normal. So next thing comes to my mind, as we know, we discussed the commonest cause around 1 year of age, the bleeding pair, remains the more than 50% cases of mucous diverticulum. So that was the first thing which came in my mind. And the plan was obviously the child, when you got admitted, hemoglobin was 9.9 gram. Otherwise, stable child started on the IV pantoprazole. And then I planned for the mucous diverticulum. It was just a weekend, Diwali, Saturday, Sunday was holiday. Child admitted on Friday evening after 6 o'clock. And I wanted to get a mucal scan. So obviously it was not possible to get it done for the next 2 days. So we planned it on a Monday. I have started the baby on a Friday itself with the injection pantoprazole, and then I stopped on the Sunday to get a mucal scan. Anybody may want to make a comment on this? Do you?
Yes, so we need to give a PPI or a H2 blocker before a mucal scan, because we need to decrease the uptake by the gastric tissue. So there's a mucal.
So this, what I did was wrong, that I should have continued to give pantoprazole till we get a mucal scan done. But I stopped on the previous day. Probably initially I thought probably giving anything H2 blocker or pantoprazole may not help in the diagnosis. But retrospectively I realized it is not a correct thing to do it. In fact, you give pantoprazole or H2 blockers, it helps in increase in the sensitivity because it retains the technetium per technete in the gastric mucosa, which helps in diagnosing better. So after 48 hours, we did a Meckel scan, that is on Monday, and this is what we saw. There was a uptake along with the stomach, as you can see here. This is the small point here in the right iliac fossa, and that was nothing but a ectopic gastric mucosa. So it confirms our diagnosis, suspected diagnosis of the Meckel's diverticulum as the cause. And so the same child was subjected next day immediately for the laparoscopic surgery to confirm again the diagnosis. This is what you see picture is a laparoscopy, this is a Meckel's diverticulum. And subsequently, obviously, with the same incision, we have to extend the little bit incision to deliver the bowel out. That is what you see here, the Meckel's was brought out one of the port side, and the wedge resection of the Meckel's diverticulum was done. And the bowel was put it back into the abdomen. And histologically, it was confirmed Meckel's diverticulum with ectopic gastric mucosa on the ileum. So post-operative baby settled well, discharged on the 6th day. Once he started oral on the 4th day, and the 6th, 7th day we discharged the baby. So about the Meckel's diverticulum, as we know, if you remember our MBBS days or the surgical days, it is one of the common cause of the, lower GI bleed. And it was described by the German anatomist way back in 1806. He was the first to say it was a remnant of the omphallomesenteric duct. It is seen in 2% of population. The male to female ratio is 2. It is always 2 feet away from the IC junction and 2 inches long. And there are two types of mucosa that you see ectopically. One is gastric mucosa, sometimes get a pancreatic mucosa. And the complication is commonest is a hemorrhage followed by interstitial obstruction. You can get interstitial obstruction because of either intersusception, because of the band, because of volvulus, and sometimes the impaction of the foreign body within the Meckel's diverticulum itself. Third common complication remains diverticulitis, umbilical discharge because of remnants, and rarely malignancy. Meckel scan is a very diagnostic specific, almost 95% of cases, and sensitivity is 85%. And surgically, if you see a Meckel's diverticulum during an accident or during any other surgery, whether you should remove or leave it inside. Normally, we try to leave it inside unless it is asymptomatic. And this is a few photographs. This was the one child who had a recurrent intersusceptions, who was almost third attempt of the reduction. 4th time when he came, this was the underlying cause was the Meckel's diverticulum, which was reduced laparoscopically. And same child's another video. This was the Meckel's diverticulum. Again, same thing was done just to trying to show this Meckel's can be a cause of the recurrent intersusception in an older child. And this was the one of the patient. So again, similar what we deliver from the umbilical port and exercise the Meckel's diverticulum. Previously, when some of these patients, the intestinal obstruction presents with a small intestinal obstruction with the intersusception with a gangrene suspected, obviously they need an open surgery. And as I said, one of the common causes is intestinal obstruction, and because of the underlying pathology remains sometimes the Meckel's band, which causing the obstruction, and volvulus. Fourth is the Meckel's diverticulitis. And as I made a comment, what you do for accidental diagnosis Meckel's diverticulum. This was one of a recent child who had a common cloaca. She had a difficulty in passage of urine. What we did, use a Meckel's for the Metrophenol procedure. This is the augmentation patch and the Metrophenol used for the Metrophenol. So, can I continue my further? Okay, time is over. Okay, sorry. Then it will be difficult. Anyway, I will skip some slides. I'll go further then, since we have discussed already most of the points. But we'll go the algorithm. So suspected acute GI bleed, initial evaluation followed by the resuscitation. The next comes the upper GI endoscopy. And if that is normal, obviously then next things go for a colonoscopy or a CT angiography. And if the source is found, then go for specific treatment. No source is found, then go for if the still child continues to bleed, go for CT angiography. and no source is found, open surgery, laparoscopy or open surgery, and then open the intra-bowel and go put the scope inside the lumen to identify the source of bleeding. Capsule endoscopy, madam has already mentioned, it should be done only for patients of the occult bleeding and suspected chronic bleeding. I think then I'll skip it since I'm already over skipping. Thank you.
Thank you, dear faculty, for your time and expertise. Now I request all the dignitaries on stage to please proceed towards the felicitation station. Thank you.